UP AROI and ECMO, and has published many research articles in national and international journals. Welcome, ma'am.
Thank you, Aditya, for the warm welcome to me. And I would like to take an honor to welcome our speaker, and she is Dr. Tabassum Wadasadawala, and she is a very known figure. She doesn't need any introduction, but still, I would like to highlight some of her specialized thing. Like she specializes in breast oncology, and she is a professor and consultant radiation oncologist at TMC Mumbai, and she is leading several research protocols, and with a special interest and also a PI of several randomized trials, including the concurrent adjuvant chemo RT, dose fractionation and whole breast reconstruction, Portok trial evaluating H2O2 as a radiosensitizer, and she has more than 70 publications to her credit in various peer-reviewed national and international journals. So, Dr. Tabassum, you are welcome, and she'll be talking on the paradigm shift from 2D planning in breast cancer to the latest IMRT planning. Welcome, Dr. Tabassum.
Yeah, thank you, Dr. Neha, for the introduction. So I think the advanced techniques and all will be discussed in the future talks. So for today, I am supposed to cover and teach conventional radiotherapy planning, which is essentially 3D conformal radiotherapy. So I would like to share my screen.
Yes, ma'am. I request all the participants, if you have any questions, you can post it in the chat box. All the questions we can take up at the end of the presentation.
So, in this talk, I would be covering the indications for adjuvant radiotherapy, what is there to be seen in pre-planning, then the simulation, actual planning on TPS, as well as the plan implementation or the plan execution. So, coming to the indications, I would like to mention here that I am not going to go into the evidence related to each indication, but I'm just listing out the indications and where radiation can be de-escalated or escalated, and the evidence will be covered, I think, or would have already been covered in the previous lectures. So, coming to the scenario of both post breast conservation, large majority of the patients merit adjuvant radiotherapy because it reduces the chances of breast recurrences as well as overall recurrences, and hence it translates into breast mortality reduction. Breast cancer mortality is also reduced, as well as overall mortality is also reduced. However, having said that, there are a group of patients in whom radiation can be omitted, safely omitted, and this is based on the PRIME trial. And what were the criteria for omission? Patient can be considered for omitting breast radiotherapy. Elderly women more than 65 years and older, early breast cancer, which is just as low risk. And what are these tumors? Low risk tumors are hormone positive, axillary node negative, and tumor size up to 3 centimeter with clear margins. And other factors like the tumor grade and the lymphovascular invasion can also be considered on case-to-case basis. If there are multiple such high-risk factors, then radiation should not be omitted. And omission is only reserved for low-risk tumors in elderly. So I would like to go through this chart of NCCN, and what I have done in this chart is I have highlighted few areas as blue, which means that we should be doing or following what is written. But there are certain red areas wherein we would not recommend to follow these things strictly. Now, for example, if you have to see PN0 0 patients, the NCCN mentions that comprehensive RNI should be given in central medial tumors, T3 tumors, or T2 having high risk factors. But this, according to me, seems to be an overkill. And of course, whole breast radiotherapy with boost should be given. And there will be, I would be covering the indications for APBI. They can also be considered for APBI or omission, as I already mentioned. Coming to PN1, that is 1 to 3 lymph node positive cases. Whole breast radiotherapy with boost is definitely recommended. And here again, they have said that you should be doing comprehensive regional nodal irradiation. And here, I would also like to highlight that whatever the trials have on RNI, they have included, radiation of the various trials have included various regional targets, and it ranges from supraclavicular as well as internal memory. So the evidence for internal memory irradiation over and above irradiation of the supraclavicular fossa is weak, and the whatever RNI trials were done, they have not dissected out completely the additional role of internal memory nodal irradiation. So this also I have highlighted in red. And in patients with node 4 and more node positive, so definitely there is strong evidence to consider whole breast radiotherapy plus boost as well as comprehensive RNA, and including the portion that is axilla that is undissected. So coming to the guidelines for APBI. So the guidelines for APBI were devised based on expert opinion empirically by reviewing the literature, and these were given in 2009. And as you can see, patients were categorized in 3 categories: suitable, cautionary, and unsuitable. And there were a number of other factors that were considered, basically tumor size up to 3 centimeter were included in the cautionary, and anything more than 3 in the unsuitable, and negative margins by minimum of 2 millimeter. And in the cautionary group, limited or focal LVSI was allowed, and ER status was considered, negative status was again considered into the cautionary group. And of course, the lymph nodes have to be negative and unifocal tumors. So in 2016, because there was a lot of literature of reporting that these consensus statement is not actually applicable for selection of APBI, because many series had reported outcome were not similar amongst the suitable and cautionary groups. That's why the guidelines were revised, and the age cutoff was brought down by 10 years, and the suitable group was more than or equal to 50 years, and patient between 40 to 49 were in the cautionary. So this was a major change, and because of which more patients could be offered APBI. Now coming to the Jack-Castro guidelines that were also given in 2010, and here again, if you see, this was almost similar, but the difference was that the ERPR status was disregarded, and in the Jack-Castro guidelines compared to the Astro guidelines, and both the guidelines did not take into account HER2 receptor status. Rest of the factors were almost similar in the 2 guidelines. And recently, last year, we have this consensus recommendations for APBI, and what they have recommended is patients having low risk disease, that is grade 1, grade 2 ER positive histology. And here again, the age cutoff is 40 years, because the brachy trial, also brachytherapy, randomized trial on brachytherapy included patients more than or equal to 40 40 years. So various criteria have been given for case selection, and where APBI is strongly recommended, and there are certain scenarios where it is the recommendation is conditional. So you can go through this paper, which is a good paper summarizing the evidence for invasive breast cancer as well as for DCIS. Now, coming to the indications in the post-mastectomy setting. So, if you see again, the red areas are the areas where I would not be, following these guidelines, because it will again be overkill to include node negative patients with for comprehensive regional nodal irradiation, and for patients who are axillary lymph node negative and T3 tumors, again, PMRT should be considered, but comprehensive RNI can be on case-to-case basis. Same is true for 1 to 3 lymph nodes, and there is no until recently, after the EBC-TCG 2014 for post-mastectomy radiotherapy was published, we were happily giving radiation for all node positive, even for N1, that is 1 to 3 lymph node positive. But recently, Supremo trial was presented, wherein we have the data only in abstract form, and here this trial included both node negative high risk patients as well as N1 patients. But mind that the N1 patients were majoritarily single node positive. 2 or 3 lymph node positive patients were few. So this trial was a negative trial, and hence we await the results of the Supremo trial in the form of a full paper. And we are also doing the randomized trial called NNBC trial at TMH, in which we have already randomized around 480 patients to radiotherapy versus not for high risk patients, node negative post mastectomy in T1 and T2. The indications in the node negative and in 1 to 3 lymph node positive are likely to change awaiting the results of these trials. Now, let us talk about the indications for regional lymph nodes. Coming to the internal mammary, this is a very, very debated topic, because as you have seen, majority of the guidelines do strongly recommend giving internal mammary comprehensive irradiation. RNI includes internal mammary as well. But here again, I'm not going into the details of the trials, because all these trials had impact on the reduction of distant metastasis, and hence there was a improvement in the DFS, but the trial had primary endpoints of overall survival, and there was no overall survival benefit. That's why at TMH we are not strong proponents. We are not proponents of doing prophylactic internal mammary irradiation, and that's not a standard protocol as well. However, we do internal mammary irradiation for patients having IMN positive at baseline, and obviously all these patients undergo neoadjuvant chemotherapy, but those patients not responding to chemo, and there is residual Goros disease after NACT, we can offer boost, and also debulking surgery can be done of the gross node, and the internal mammary nodal chain can be irradiated. However, having said that, the EBC-TCG meta-analysis, which was published a year ago focused specifically on RNI, did strongly recommend that prophylactic IMN irradiation should be considered for high-risk cases. And what were these? Those with 4 and more lymph nodes positive and medial central quadrant tumors. And this again, the benefit was not solely due to inclusion of IMN. So the undissected axilla and supraclav could have contributed to the benefit. So we cannot derive the entire benefit designate the benefit to internal mammary irradiation. Now, axilla management of axilla has revised over, so is changing rapidly, and over the last few years, the management of axilla has changed completely. So, axillary lymph node dissection is no longer done in node negative patients, and hence patients are undergoing sentinel lymph node biopsy, and patients having intermediate risk of post-positive SNB should be given axillary radiotherapy based on the MROS trial. And other indications of axillary RT is residual disease after surgery and inadequate axillary surgery. So these are the current indications for axilla. And for supraclavicular irradiation, it is obviously any lymph node, axillary lymph node positive pathologically and clinically also, prior to NACT, if the lymph node has been proven to be positive. Here again, we are awaiting the results of the RTOG 1304 trial, in which the omission of RNI is being tested, and we await the result of this trial before we can personalize the indications for radiotherapy based on response to neoadjuvant chemotherapy. So this was all about indications of adjuvant radiation. Now coming to the next part of the lecture, in which we will be talking about the pre-planning audit, the importance of pre-planning audit. You can see the sheet that is there in which we document all these details, and a clinical review in the clinic whenever the patient is referred to the OPD. From that time, you can figure out what are the likely possibilities or nuances that a patient we may have to navigate through for radiation planning, especially patients with left-sided disease or bilateral patients having bilateral breast cancer, and those with comorbidities, specifically a patient with pacemaker in situ. And also review the type of surgery, because we see so many types of reconstructive procedures, oncoplastic procedures nowadays, that it is very difficult to keep pace with the evolving techniques. However, you have to be aware of all these types of surgeries, because it has direct implication for radiation planning. Also, based on the in the target volumes, patient treatment position can be decided, then whether 3D-CRT, IMRT or DIBH is required. And this is how, based on the stage and the target volume, it is important to review the diagnostic imaging. We routinely do this in our clinic, and we decide based on the need for DIBH based on the anatomy of the patient, the target volumes, and the medical history. So patients having unfavorable anatomy and those requiring internal mammary nodal irradiation are generally considered for DIBH, because we don't have the luxury of providing DIBH for each and every left-sided patients. That's why we have to triage our patients for DIBH. Now, on the day of simulation, you have to see n number of things, whether the wound is healed, sutures or staples are in situ, whether there is any seroma collection, not only in the tumor bed or the chest wall, but also in the axilla, because that can also impact your planning. What is the extent of the scar, whether it is within the confines of the tangent, or it is crossing midline or the mid-axillary line. Also important to note is the arm movements, and this can be also noted in the OPD during evaluation, and patient can be sent for physiotherapy at that time point itself. And also whether there is any dog ear or any excessive skin folds in the area to be treated. and you can preempt some high risk of radiation toxicity in patients who are having short neck or having folds or dog ear, and patients can be counseled prior to radiation planning. And it is also very important to avoid delay in, especially in patients having locally advanced disease, because these patients would suffer from recurrence if there is undue delay in starting radiation. So these are the steps of radiation planning. Of course, positioning and immobilization is very important, and the important aspect to for radiation planning, as like in any other site. Then localization of the tumor bed, and the target volumes on the tangents, and field selection, how the dose distribution is, how to control the overdose volumes, and then calculation and verification, as well as execution. So these are the examples of the issues of pre-planning that we face occasionally. So you can see sometimes patients who have been operated and sent to our clinic for radiation planning within 2 to 3 weeks of surgery, you will find that there will be a lot of seroma collection. Hence, you should not be very enthusiastic to simulate the patient within 10 days or 2 weeks. So you have to allow time for good wound healing, which generally takes 2 weeks. So ideal time, I would say, is 4 weeks, where you can do a radiation scan to because the seroma also settles by then. And for patients who do not have this seroma being where is continuously draining, and even if the patient is 3 to 4 weeks, still you are finding a sizable collection of seroma in this planning scan, then we do send patients for pigtailing or for few days. And once the seroma is then completely drained, then we resimulate. So this is also, the lower panel is an example of the dog ear, which and the scar is also going up to the posterior axillary line. So these are all the examples of scenarios where you can anticipate some difficulty in radiation planning. So this is the slide which is describing the importance of reviewing the diagnostic imaging, because it helps you to know the exact extent of the disease and what is the burden of disease, because a patient having infraclav lymph node, a Rotter's lymph node, or an internal are very high risk, and hence it is important not only to see their baseline imaging, but also response imaging, and how the disease is responding overall, the primary disease, the nodal response, and the surgery, whether it is R0 or not. And how we check the need for DIBH is shown in the lower three diagrams. As you can see, we have drawn a line from the midline till the point where we generally put the lateral fiducial, and we see the extent of heart, that is the distance of heart that is coming in the field. And in the sagittal section, you can also see the cardiac contact distance. So many patients may not have heart distance that is more than 1 centimeter in the axial plane, but in the sagittal you can see that the length of distance in contact with the chest wall is higher in few patients. So such patients would also will benefit from breath hold technique. And another important thing that is helpful to see is the depth of the tumor bed. As you can see, the tumor is just up to 2 or 3 centimeters centimeter, but in TMH, surgeons do go on to the base, that is to till the pectoral muscle, and hence you would typically find the clips over the pectoralis muscles, and hence you end up irradiating the whole depth of the tumor bed, and you can see the depth is 4.9, which itself implies that the patient would not be able to encompass this target volume in electron boost, and hence this patient is likely a candidate for IMRT. So how, as I already mentioned, how we choose between 3D CRT and IMRT, we review the baseline scans and location, depth of the tumor bed. So location is also important because a patient having tumor in the lower inner quadrant will not have a deeper tumor bed, but will be overlying the heart. So that is also an important important thing to be noted. So if it is possible to encompass in electrons, roughly around 3.5 to 4 centimeter depth of tumor bed depth would be encompassed with electrons, or if electrons is not feasible, then mini tangents can be considered. And however, if the patient is already planned for IMRT because of other reasons like internal memory, radiation, or axillary radiotherapy, so SIP can be given along with the whole breast RT. For the internal memory lymph nodes also you have to see. Generally, what the techniques, the conventional techniques, that is partially wide tangent or photon electron, are no longer followed now, because you cannot adequately cover the internal memory chain with these techniques. Hence, more common is IMRT for RNI. As I already mentioned, the how we select cases for DIBH. So if the patient is having more than 1 centimeter of heart inside the portal and the patient is compliant, she is able to understand your instructions and follow the DIBH practice, then you go ahead with DIBH. Otherwise, free breathing IMRT can be offered, because conventional radiotherapy will lead to either underdose because of cardiac shielding, or excessive irradiation of the heart, because you would not like to underdose the target volumes. So this is our protocol for DIBH training. We involve our technologist in this, and this is a teamwork, and a comprehensive training module has been devised for patients, so that they feel empowered, and it improves their compliance and reduces their anxiety. So we do offer give them a spirometer for practice to improve their lung capacity, and in addition, we give written instructions. We also shooted one teaching video for the patients to understand the importance of DIBH correctly. And verbal coaching is done, as well as when the patient comes for simulation, we also do audio video feedback on the machine. So this is the example of the written instructions or the sheet that is given to the patient. And on the right hand side, you can see the practice sheet, which we give to the patient on the day for day one of counseling. And we ask the patient to practice at least 5 times in a day. And in each session, they should practice at least 10 times. And the most frequent observation, or the breath hold, or the spirometer reading is to be documented. And we recommend at least patients should be practicing for 5 days prior to simulation, and they should keep on practicing till the end of till the radiation is concluded. Now coming to the discussion on positioning, what are the pros and cons of supine and prone position? So the supine position is most common because it is easy for setup. You can match the nodal fields with the chest wall fields, and you can see on the patient skin marking is easily possible, and obviously it is more comfortable to the patient, and the beam entry and the flash can be seen on the body during setup. However, it may not be suitable for patients with large breasts, in whom the folds are excessive, especially in the inframammary region, where there is because of the fold, there can be loss of skin sparing, and you may end up a patient may end up having more reactions in the inframammary fold. Also, immobilization may be difficult in women with large and pendulous breast, and patients having restricted arm movements also find it might be difficult to reproduce the position. And few patients have a fold not only in the inframammary region, but they also have it in the neck or in the in the outer quadrant, in the axillary tail. When you talk about the prone position, the advantage is that it leads to the narrowing of the breast shape and making it a homogeneous structure for radiation. And OARs are separated from the breast tissue, leading to reduction in the lung and the heart volume. And respiratory movement is limited, so intrafraction motion is also reduced. And obviously, it reduces the folds, but there are a lot of disadvantages of prone position, because it is not reproducible, and hence it leads to large setup errors. It is uncomfortable to the patient, because generally such patients are obese, and it is very difficult to get on these patients to the couch for lying prone. And you cannot match the nodal field. Boost is also delivered in supine position, because the boost region also becomes very tubular and elongated, and it is not advisable to deliver boost in prone position. Because of all these issues, it is a time consuming procedure, and obviously it is not suitable for inner quadrant tumors, because you cannot then spare the contralateral breast, and it becomes technically difficult to place the beams for adequately covering the inner quadrant tumors in prone position. Needless to say, we do have to use the breastboard which has an inclination, because it has a number of advantages that it offers. Firstly, it reduces the need of collimating the beam, which is beneficial in field matching, because we don't have to collimate the beam due to the inclination. And thus it reduces the match line inhomogeneity. It allows for comfortable arms up support, and most importantly, it brings the arms away from the breast so that it is not irradiated. And several adjustable features are present with the breastboard. They help to keep the arm, wrist, shoulder, and head in a comfortable position. And you can see the diagram below. This is the patient in the CT image. Patient is lying flat over the couch, and you can see the amount of lung that is coming in the field. But if the patient is on an inclined board, you can see how the lung exposure is reduced because of this. And the advantage in field matching is also obvious in the first diagram. The arm elevation, also it is recommended that both the arms should be arms above head, because it is more comfortable and reproducible. And it is symmetrical, because it will reduce the chances of roll or rotation of the torso. And it is useful to move arms from the chest wall comfortably. So, patients coming for radiation immediately after surgery need more attention with respect to the shoulder exercises, because their arm movement might be restricted. Hence, it is difficult for them to lie down on the couch without pain. It will be painful, and then they will move during planning. And most importantly, it is also imperative to also review the SCF region, because especially in short neck ladies, you might see skin folds in the SCF region. And I know it's a common practice to use thermoplastic mold, but the thermoplastic mold is not very strongly recommended, because it is recommended to avoid. Is not recommended because a bolus effect will be there, and there can be excessive skin reaction. And breast movement is primarily due to respiration or variation in the alignment or the arm position. Hence, more attention should be given to for correction of these things, rather than, I mean, the movement of breast per se. And even if you use the thermoplastic mold, it will not guarantee that the breast inside will not move. Hence, this is an example, or the indication, where I would, the only indication where I would consider or recommend a thermoplastic mold. And this is when the breast is falling laterally. So you can see the white arrow in the first diagram. There is a big fold that is coming, and with the help of the thermoplastic mold, this fold has been beautifully reduced. So primarily, it should be for cases where the breast is hanging laterally beyond the mid-axillary line, and these would be the patients that would actually benefit from ORFIT use. Now, coming to the CT acquisition, it is before. It is a standard acquisition of the CT. 5 millimeter thickness cuts are enough for 3D conformal radiotherapy. But if you are doing IMRT, or you want to do some other additional targets are there along with breast and tumor bed boost, then finer cuts of 2.5 millimeter can be considered. Patients, and before completing the procedure, before removing the patient from the couch, it is important to apply skin marks, whether with the help of tegaderm or tattoo, anything is fine. And clinical references for the tumor bed scar or the extent of mastectomy scar should be documented properly in your RT notes, along with the oncoplastic procedures. And if the patient is for DIBH, then the reference between the free breathing and the DIBH reference points should be also documented. And it is advisable to capture positioning photograph in patient's phone, because especially for busy setups, it becomes easy for plan implementation, because the team keeps on changing, and also there might be some lag in the planning, so it becomes easier. A quick review of the CT for the adequacy should also be done. You have to quickly review whether there is any seroma, whether the FOV is adequate, and also the position of the patient with respect to the alignment and the neck position. So document the breastbone setup parameters on a sheet, so that it becomes easy for patient setup on machine. So this is how everyone of you must know what are the clinical landmarks for breast planning. So medially it is at the midline, or it will across the midline if the scar is coming until the midline, and you have to give 1 centimeter margin to the scar. Laterally, it is 2 to 3 centimeter beyond the palpable breast tissue in case of breast conservation, or at the mid-axillary line in cases of mastectomy. And superiorly, it is at the low inferior border of the sternal head of the clavicle, and inferiorly at the contralateral 1 or 2 centimeter margin to the contralateral inframammary fold. So you have to check the laser alignment, wire the scar, wire the breast, and if it is an IMRT, it is advisable to wire the contralateral breast as well, especially in obese patients. Fiducial placement and CT scan is acquired with 5 millimeter thickness. So the need for field matching, if you are planning radiation to the supraclav region as well as the breast, it is necessary to do field matching, because the hotspot is caused by the divergence of the tangential beam in the supraclav beam and of the supraclav beam in the tangential beam. And hence, if it is not corrected, there can be severe match line fibrosis because of the inhomogeneity and overdose that can happen at the junction, and it can also lead to rib fracture or brachial plexopathy. So how we can do field matching? There are a number of ways in which divergence can be minimized. First is using a collimation or an angulation. So that will also help to reduce the divergence. The half beam block, the breast cone, these are all the earlier ways of earlier, the breast cone is the older technique where we used to use this when we used to do clinical planning of chest wall cases for mastectomy cases in the OPD, and the breast cone used to was to be applied during setup, and hanging block or the monoisocentric technique. So most common is the monoisocentric technique nowadays. Before we start off with the planning, there are basic terms which should be known in breast planning. So this is the diagram that is explaining all these distances. First is the maximum heart distance. So this is not in the central axis. It is in the plane anywhere where the heart sill out is maximum within the portal. So that is the maximum heart distance. Maximum heart length is also is the length which is in contact with the uh, longitudinal measure of the cardiac exposure within the portal. CLD is in the central axis. So it is the distance of the lung that is along the central axis. So this is the white is the central axis, and CLD, which is the arrow in red. Lung length is similarly, you can see that it is coming from the superior border, from the superior border almost two-thirds of the lengthwise the lung is getting exposed. So that is the lung length, and central flash distance is the 1 or 2 centimeter distance that is given anteriorly for accounting respiratory motion. So that is the central flash distance, and inferior central distance is again in the central axis, and it is the margin to the inferior part of the breast. So planning, coming to the planning, it starts with the important reviewing patient registration, and again we will, before planning, we will review the adequacy of the CT scan, and whether there are any artifacts, and confirm the prescription or dose prescription as well as the target volumes, and delineate the target volumes, which is not mandatory for CDCRT planning, because of our busy setup, we are not able to plan cases which are contour cases which are for 3D conformal or tangential RT. But we do contour OARs in all the patients, and also any high density structures, because the treatment calculation algorithm will have errors if you don't replace these high density structures. And it starts with setting up of the user origin, and then inserting the couch. And before any calculation is done, it is also important to review the body contours for inaccuracies, because the system populates the body automatically. But in especially in patients who are having very thin chest wall, the body might go inside the inside the chest wall, and then after calculation you will find that the dose is not getting generated. So it is better to review the body contour before you calculate any plan. So coming to the planning of whole breast radiotherapy planning for breast alone. So this is the standard geometry is parallel opposed bitangential beams, and it is advisable to angulate the posterior beam edges to match each other to avoid divergence into the lung tissue, and angle should be more than 180 degrees. And as I already mentioned, there should be a flash of around 1 or 2 centimeter, and draw a line joining the two fiducials at the user origin slide, and then finalize the field borders. If your clinical marking is accurate, you may not have to move the the field borders. But if you feel that the tumor is located in the outer outer quadrant there is a need to move the field borders, then that clinical decision has to be taken after reviewing the CT. Then inserting the new plan and the new fields and prescribing to the ISO center. So this is only for breast alone. So either you can prescribe to the ISO center or to a reference point, which should be placed close to the center of the target as far as possible. And either you can do the planning with half beam block, or you can do it isocentric. So in the half beam block, the prescription is always to the reference point. And do not place the reference point in the build-up region for the energy chosen, or in the air, that means in the lung, or in the blocked region of the MLC, to avoid calculation errors. And in case of chest wall, the additionally you would link a bolus, because most of the because on linear accelerator there will be skin sparing effect. So if it's a high risk case, then bolus is advisable. We put bolus for all the fractions for mastectomy cases. And the use of wedges, physical wedges are no longer used now. These are dynamic wedges with the help of MLCs are only providing this wedge effect and control. These help us to control the overdose volume using the field in field technique to achieve our intention to achieve a global Dmax of 105%. So this is how using half beam block as well as the isocentric technique. Here the isocenter is within the breast, but in this it is at the posterior beam edge, and there is the posterior portion of the beam is blocked. So this is a half beam block arrangement, and the heart is shielded. So this is how the beam placement is done. And these tables show that we have given an angle of more than 180 degrees, because to match the divergence of the posterior beams. So, and then the overdose volumes are blocked, and this is how a field in field is created in order to get a homogeneous dose distribution. So, how can you modulate the dose in 3D conformal radiotherapy? The objective is to get adequate target coverage as well as dose homogeneity. So, the options are to improve the plan is by using higher energy. So, if you have a 10 MV photon, it can be used along with a mixed beam plan with 6 MV photons, or you can the other way to reduce the dose is using field in field, or you can go for inverse plan IMRT, VMAT, and also play with the location of the reference point. So the reference point is very sensitive. So it depends where you have placed the reference point. So you have to balance between tumor coverage and the hotspot. And also you can play with the weightage of the two tangential beams and employing physical wedges if required. So these are the steps of monoisocentric techniques. So the what we discussed was only for breast, but now here we would be discussing the monoisocentric technique. So first I am explaining the placement of the beams for the breast, lower part of the target volume, that is the breast. So here the isocenter, generally we choose the isocenter to be placed at the lower border of the inferior border of the SCF field, and the gantry is rotated, making the central axis parallel to the line joining the two fiducials. I will explain in the next slides. Then 1/4 of the field is open, while making the posterior end of the field parallel to the line joining the two fiducials. And similarly, a flash is given, and once one beam is placed, the opposing beam is also generated, and collimator angle of 90° is required if you have to insert a wedge, and bolus for mastectomy cases can be added. And a reference point has to be placed very carefully. Initially, it should be in the middle or the center of the target volume, but later it can be moved depending on the requirement, the patient anatomy, and the interfield distance. One has to avoid placing the reference point within 2 centimeters of the superior and the posterior field borders, because what we noticed was when we initially moved on to the MIT technique from DIT technique, we found a miscalculation of the MUs that were generated from the TPS and compared to the manual MUs. So our physics team had done a QA for consecutive 50 patients, and then they found that the MIT technique, the reference point prescription based, they need more different off-axis ratios as well, and hence they should not be very close, and the wedge factors, they should not be placed very close to the superior and the posterior beam edge. So this is the stepwise example. So this is where at the lower part of the clavicle, the isocenter has been placed. Generally, we put it at the lateral end of the supraclavicular field. And so this is the whole field, four parts of the field. But in radiation or in irradiating the breast, we will close 3 parts, 3/4 of the field, and open only this lower quarter of the field to irradiate the primary. So this is how the beam placement has been done, and a reference point has been inserted, and dose calculated, and you can see that the dose is covering, the target is adequately covered. And the field weightages that can be used for reducing the hotspot can be on an increment, on a small increment basis. You should start with 5%, then you can increase slowly 7, 8%, 10%. But whenever it is more than 10% in any subfield, you have to be cautious, because then the dose coverage will get reduced at that wherever the subfield has been used. So you have to keep on going back to the axial cuts and see whether the dose coverage has been compromised or not. So if it has not compromised, then you may consider increasing the weightage of the subfields, but it is back and forth before you get an optimal balance between the coverage and the hotspot. So if this is not working, then you may consider changing the position of the reference point. So you can see in this field parameters here, X1 and X2 both are open. But in the lower part, we have closed the X2, only X1 is open. Similarly, Y is also closed. So here you can see Y1 is 17 and Y2 is 0. But here initially it was 8.5, 8.5. So this is how the MIT field placement for breast primary is done. Coming to the SCF, you again create a new plan, bearing in mind that the XYZ should be the same. It should not be altered at all. Again, you have to insert a new field, an anterior field, and obviously we know the clinical landmarks. It encompasses the medial 2/3 of the clavicle and till the midline, and create a new reference point and place it at a depth that is beyond the Dmax of the energy in use, and do not place the reference point on a bone or below or behind it, and normalize the reference point and calculate the plan. So you have done a basic calculation and you feel that the coverage is not good. So what are the ways in which you can improve the coverage in the supraclav? It is with the help of increasing the depth of the reference point, but you have to be mindful about the 107% volume. If it is increasing, then increasing the depth of the reference point will not work, or it will not be sufficient. Then you will have to use a higher energy beam, increase the beam energy, or make an APPA plan with unequal weightage, give low weightage to the posterior beam. So this is how planning for supraclav is done. So you can see in this DRR the field borders for the supraclav, the dose is calculated, and here we have angulated the beam by 10 to 15 degree, because here you can see how the dose to the spinal cord, as well as to some extent to the esophagus also, it can be reduced. Uh, So typically it is 8 by 8 centimeter field size. And you have to evaluate the dose again in the sum plan for the final check. So if you will evaluate the individual plans, it may not be sufficient because of the scatter dose. The sum plan would be the best thing to evaluate, and final checks can be done, because sometimes you will feel that there is some 107% small volumes or pockets appearing at the junction or at some other place. And make sure that the isocent in both the plants is exactly the same. And if you are not able to achieve a Dmax of 105, 107% overdose up to 2 cc is acceptable. I mean, you can accept more than that as well, but I would not recommend that otherwise, because the patient might end up in having problems with radiation dermatitis. So this is an example of an APPA portal where you can see only 20% weightage has been given to the posterior beam. And here the coverage is only with Enphase portal with 6 MV photons. So APPA beams can also be given. Now coming to the internal memory nodal chain irradiation. So it is a very technically challenging, it was technically challenging to irradiate because of the multiple junctions and multiple OARs like heart, lung, and contralateral breast. So traditionally a small portal was put for photon electron planning. Superiorly, it used to match the supraclav portal. It was of opposite, it would cross the midline at the opposite contralateral sternal edge, and a 5 to 6 centimeter beam width, and it would cover the upper three intercostal spaces. So it either a direct anterior electron beam or a partially wide tangent or a photon electron combination was used. So there were a lot of issues there with this photon electron technique, because it is difficult to get an adequate coverage with conventional techniques. Only coverage up to 80% is acceptable in prophylactic settings. But if you are irradiating for initially node IMN positive cases, then you should have adequate 95% coverage. And these conventional techniques cannot give that much good coverage, and hence IMRT is recommended. And it is also recommended to do DIBH for this in order to reduce the dose not only to the heart for left-sided but also to the lung. So this is an example of the wide tangent that you can see that the internal memory vessels have been contoured, and the tangent has been placed posteriorly to cover this internal memory vessels, and it would go across midline. And see the amount of lung that is coming, around 4 centimeter of lung is coming in the field. So these are wide tangents. So wide tangent would be wide throughout, but if it is shielding in the lower part, the lung, it will be partially wide tangent. So this is the field is wide in the first three intercostal spaces, and in the lower intercostal spaces the lung is blocked. So this reduces lung as well as the heart is blocked. So this reduces the lung and the cardiac exposure. But again, the coverage, you will not expect more than 80% coverage with this. So we used to plan this internal memory nodes initially, but by and large now we do not so frequently do internal memory irradiation with partially wide tangents. We do it with IMRT only. Now coming to the axilla, an N-phase electron SCF portal is extended laterally to cover the humeral head, and these are the boundaries. That is midline. The lateral border is the surgical neck of humerus. Then superior border is at the same as SCF, and the inferior border is also same like SCF, but it is matched with the superior border of the tangents. Other way to treat axilla is APPA portals, and there used to be supplemented with anterior boost or posterior axillary boost, and there is also a technique called optimized posterior axillary boost. So these are all the older techniques that were employed for treating the axilla adequately. So what are the extent of the posterior axillary boost? It was employed to supplement the midline axillary dose because the level 1 and level 2 axillary lymph nodes are at a greater depth, and hence there was a need to provide a boost from posteriorly in order to get adequate dose to this nodal to this level 1 and 2 axilla. So it is 2 centimeter medial to the lung chest wall interface, and inferiorly it is same as that of the supraclav portal, and lateral border is at the posterior axillary fold, and superior border it splits the clavicle, and the superior lateral border shields or splits the humeral head. So typically a 10 to 15 Cray boost used to be given in this. So this is the paper that has beautifully described the various techniques. So this is in the panel A, you can see that this is the anterior portal where only the humerus has been shielded. This gray area is the axilla level 1 and 2, and this was the AP field. And this is the posterior axillary boost. You can see that level 1 and 2 lymph nodes have been given supplemental radiation from posterior side. And what they described is the optimized posterior axillary boost, wherein they have added another anterior portal apart from the main A portal. This is the B portal where they had shielded this region. And why they did this? Because if you give posterior axillary boost along with this AP portal, there is a lot of hotspot that comes. So in order to circumvent that, so this was a balance between getting good coverage and restricting the volume. But why this was all done? Because earlier on, the radiation of axillary dissection was a standard, and radiation on the top of it will obviously increase the risk of lymphedema. And if it is too much of hot volume there, so lymphedema risk would further increase. But we should not be much worried about all these things, because nowadays the management of axilla has changed completely. We do not give any two modalities of treatment, and in fact the role of radiation with respect to axillary radiotherapy management is increasing and is being revived following the data from the AMAROS trial. And I will describe the field of the AMAROS trial as well. So what they found was AP technique was insufficient to deliver dose to the deeper lymph nodes. APPA technique irradiated a larger volume, and hence it also increased the lung dose. The boost techniques, whether anterior or the posterior, they resulted in excessive hotspots in the cases. And the technique that I described, they said that it is an optimal balance between the two. These are the field designs for the Z11 study. This study that established the role of SNB in clinically node negative, but SNB positive, 1 to 3 lymph nodes. And here you can see, instead of the conventional tangent, they have moved their upper border to 2 centimeter below the humerus. And so what this led to was irradiation of the level 1 and the level 2 axilla partially. And hence it is criticized that it was radiotherapy that has led to the low recurrence rate in the SNB arm. And hence it's not that all patients can be left alone and or observed after having positive SNB. So this was the design of the Z11. And in the Amaros trial, they included axilla level 1 to 3, and the medial part of the supraclav was considered as the target volume for radiotherapy. And they also gave, in a similar design, an anterior and a smaller posterior photon field that is like a boost only. And the dose was given to the full thickness of the axilla at level 1 and 2, and at a 3 centimeter depth at level 3. They gave 50 grain 25 fractions on a daily basis. And so basically the Amaros trial has established the role of radiation for SNB positive 1 to 3 lymph nodes, whether it is micro or the macro mets. So as you can see, the dose in the Amaros trial, the curve in green, for level 1, for level 2, as well as for level 3 and level 4 was level 3 was good. So this shows that axilla was irradiated adequately. Do I have time, or I mean, stop? Tumor bed boost and implementation is still pending.
How many more slides are remaining, Dr. Tabassum?
There are many slides, but I can quickly brush through. If most of the things I have covered, it's just the tumor bed boost and the plan implementation.
You can cover this because it's very interesting. I think that's very beneficial for the students to learn.
Okay. So
Okay.
if I have to interrupt, please interrupt me if I have to stop.
Maybe I think you will be able to finish in 10 minutes or so.
Yeah, I think so. I should be able to finish in
Okay,
10
then you may
another 10.
continue. Yeah, fine.
Yeah. So electron boost planning is a critical component of whole breast radiotherapy planning. It is nowadays done on CT based. That we no longer do it on clinical landmarks. So the aim is to prescribe dose to 100% at Dmax to cover at least with 90% of isodose. And various electron energies can be used depending upon the depth. And it is best to do a CT planning in the same, use the same CT for planning electron boost, because unless the patient has any serial changes in the seroma volume that is rapidly changing, it has changed from the day of starting till the end. In that case, you can repeat the CT scan and evaluate the seroma volume and the need to aspirate it if there is too much of seroma collection in the tumor bed. And it is very critical to evaluate the clinico-pathological as well as the surgical details because they help in delineation of the tumor surgical bed. And it is best to have the patient clinical photograph for complete information regarding the tumor location and the scar orientation with respect to the tumor bed. Considering so many types of oncoplasties that are done nowadays, and very thin and very deep cavities are not suitable for electron treatment. And however, it is still good enough technique for 60 to 70% of patients. So this is an example of how we customize our electron planning. So this was earlier on when we used to do a rectangular blocking. So once the tumor bed is delineated, if we measure the depth of the tumor bed, if it is between 3.5, you can easily cover it with electrons, and the electron energy is depth into 4. So that's how you can calculate the energy. And electron and phase electron planning is done. But nowadays we have moved towards customized block. So you can see how we have fabricated the cutouts for electron planning based on the shape of the tumor bed. So we take around 2-3 days, 1 or 2 days to make this electron cutout, and so this has further reduced the spill that happens because of use of non-uniform, these rectangular cutouts. Coming to 3D CRT, it can be given either sequentially or concurrently. The tumor bed boost timing can differ based on the indication. And with 3D CRT, you can use 3 to 4 static wedged fields, and the beam arrangement can be coplanar or non-coplanar. And non-coplanar arrangement helps to reduce the spill in the ipsilateral normal breast. So 3D CRT will lead to more spill compared to electrons, but it will definitely lead to less spill compared to mini tangents. And however, it requires little more intense on planning compared to electrons and mini tangents. So this is a good paper that was published by AIMS by Dr. Ritesh from AIMS Delhi, and you can refer to this. They have described various techniques of 3D conformal radiotherapy planning for breast boost. So this is a example of mini tangent where you can see. So when would mini tangent be used? It is the same opposed beam arrangement for the whole breast that has been used, but here the length is reduced just to encompass the tumor bed adequately, and this. You can see that this patient has a thin chest wall and a very variable depth of the tumor bed. The tissue and the lateral side is thicker, while in the medial side it is thinner. So it was not possible to get a good dose distribution with 9 MeV or 12 MeV electron boost. But hence we had to plan mini tangent for this patient. Of course, you can use VMAT when you are you can use it for sequential boost or for simultaneous. But if you are using VMAT, it is advisable to you do SIP, because it will give a composite plan, and you will effectively be able to reduce the spillage into the breast. So this is the dose prescription I would like to highlight here. In sequential boost, it will be full dose. That our prescription is 12.5 gray in 5 fractions. Many centers offer 10 gray in 4 fractions. So in sequential boost, your boost dose will be the full dose which you would normally prescribe. But when you are doing SIB, for example, in this patient, we have given fast forward regimen. 26 gray 5 fraction was the prescription for the breast, but for the boost it was the 32 gray. So you can see that the dose prescription was 32 grain 5 fractions. So when this is given in 3D CRT, we would divide this 6.4 into 5 fractions. So this has to be, this you have to be very mindful what you are how you are delivering the dose, sequential or simultaneous. So this is in a snapshot. It is showing the various techniques of electron boost. So is it mandatory to give boost to all patients? So it is not like that. The lower risk patients can be omitted. We can safely omit boost. So what are these criteria? These have been given by Jack Isto, and they say that patient aged more than 50 or equal to 50, up to 3 centimeter unifocal tumors, those patients having clear margins, no EIC, LV, and node negative, and ER positive tumors. These patients can be, we can omit boost. So it is important to note that these recommendations, they have not taken any grade into consideration while deciding or recommending the omission or giving indication for boost. So please refer to this paper also, which is also a good review. So coming to the last bit of plan execution, I don't think there is much to say about it. All of us would be doing this day in and day out. But I would mention here what we generally follow. We have our ERT paper, and here we write the setup depth, the setup instructions, and this is the printout that we generally give, and this is the most important thing for our plan implementation. So for at the user origin, we would note down the roll depth. So this you can see is 8.5 centimeter. So this helps to correct the roll and get a good, patient setup. And you can see this is a chest wall, a bolus has been applied, and this is a merged field. That means this was a fielding field, and all the fields have been merged. We have been able to merge these fields because they are of same energy. All the same similar energy beams can be merged into a single beam. beam. So it is delivered, you will plan as a multiple beam, but it will be delivered as a single beam. So it eases the treatment delivery. So these are the tattoos. So you will align the patient. This is how we are assessing for roll depth. So this is where the patient has been set up, and we are reading the TSD, the roll depth, which was 8.5. So it is exactly corresponding. The TSD is 91.5. And then we move on to the ISO center. So this was an MIT technique. So we have moved to the ISO center, done the PI for ISO center, and this is how the breast field is opened first, and then the supraclav field is opened. So you can see the scar is getting covered adequately. The inferior border is also adequate. It is just 1 or 2 centimeter below the opposite inframammary fold. So this is the bolus that has been applied, and you can see that the PI has the lateral tangent has also been verified, and the supraclav field is also similarly verified, and we put tegaderm at the field borders till the end of radiotherapy. So as the consultants generally do not go for plan implementation, so what we do, our residents are very well trained to see the setup for not only for 3D CRT, even for other high-end techniques, but as a policy, we would review the marking of the patient in the OPD after the first fraction. So the patient is seen by one of us at the in the OPD. So if we will then correlate with their planning parameters. And so in this, you can see that we have commented that the medial border should be increased by 1 centimeter, because it is it is very close to the scar. So this is how marking review also helps in our clinic. So this was the end of my seminar, and I acknowledge my residents, because these all three of them had done their planning seminar at different type of point, and I have taken their slides religiously. So I also acknowledge all three of them. Thank you.
Thank you, Dr. Tabassum.
Thanks a
It was
lot,
a
ma'am.
very comprehensive presentation. And Aditi, you can take up the questions
Yeah,
quickly, very quickly.
yeah. I guess there was only one question. Uh, in BCS setting, the tumor bed boost part of RT should be covered with electrons or using photons. Would cause excessive dosage to OARs. Cost versus benefit ratio.
So obviously, electron will not lead to excessive radiation of the OARs, because there is no fall off, very narrow fall off. So major our first policy is to see whether you can encompass the tumor bed in electrons. So if that is good, you have to, go ahead with that. But if it is not possible, so the case I showed you, a very thin chest wall, so the dose deposition was not possible, because the Dmax was going into the lung. So there was very much inhomogeneity because of that, and hence we planned the mini tangents or the photon beam. So with photons, you can easily shield the OAR. So I don't think so. Even giving 3D CRT should be that much of a problem. If you are able to shield the OARs, it is well and good.
Dr. Tabassum, very quickly, I would like to ask, in the end of the slide, you said that the multiple fields which we are using, and they can be combined to form a single field for
Yes.
delivery.
Yeah.
So what is the need for this? Actually, just wanted to know. Just for the ease of setting up the patient?
Yes, it is for ease of
Uh,
setup. The technologies
yeah,
doesn't
just
have to vary the
right,
choose different fields and subfields.
right.
So they are
So
all
see
merged.
the
So they have to
SSD and just,
yes,
yeah.
yes, yes.
Okay, okay, fine, fine. Thank you.
Uh, some patients develop blister on Tegadam application. Any management guidelines for the same?
Yeah, so then we just remove the tegaderm. Sometimes we burst the blister, and we leave it open, and then we have to manage it with skin marks. There's no other option to that. And you can apply some, cream, soothing cream for that. But generally, patients develop it towards the end of their treatment. So the treatment is almost going to end. Then, I rarely see a patient who would have allergy within 1 or 2 days of applying Tegaderm.
In case of chest wall recurrence, do you consider re-radiation?
Yeah, we do consider we are very liberal in re-radiation if the patient is having a high risk of, has presented with high risk disease, and we are comfortable re-radiating after, I would say, 1 year if it is really high risk. But we are very safe in practice if it is DFI is more than 2 years, surely.
Next is what are your thoughts on indications of radiation therapy and radiation treatment field in early breast cancer post neoadjuvant systemic therapy?
Early breast cancer. So generally, an early breast cancer would undergo a BCS only. So obviously, you cannot omit, radiation in a BCS case. But yes, for mastectomy, as I said, the RTOG 1304 trial is looking at, for patients who have undergone early breast cancer, who has undergone NACT, and who has been planned for mastectomy. They are considering omission of chest wall RT. And for patients who are considered for BCS, they are considering omission of RNI. Regional nodes, only give breast RT.
I guess
Adit,
that's all.
any other question?
No, ma'am, it's done.
So with that,
There's one more question. Bilateral breast irradiation, do you consider for
For
or
means, I think the question is incomplete.
incomplete? Yeah.
So bilateral radiation, actually, we do very comfortably. We have, I think, one of the largest series. We have published retrospective data as well as dosimetric data as well. So particular radiation, yes. So bilateral radiation is very challenging to do with 3D CRT, I would say, because there are so many junctions, so many, and you have to keep a gap of 1.5 centimeter between the two medial tangents, and doing all that, it is very, very time consuming. Reposition the patient on one side, do tangents on one side, and then reposition the patient to the other side. So it is very time consuming. So we do IMRT or VMAT for all our bilateral patients. And we have, on for VMAT, we have, our physicists have come up with a single isocenter, two isocenter plans. Now it's very smooth, very easily done. They don't take so much time to do planning for bilateral cases. But yes, we advise that the patient should be treated with DIBH, because they receive radiation, scatter radiation from both right as well as left. So they should be offered DIBH VMAT.
Uh, if you don't have breathing control methods available, how to avoid heart radiation in case of left side radiation?
So first of all, you have to know, you have to be very clear that you have to adequately cover the target volume. So if the patient is, even if you have DIBH, but if the patient is not performing well and she is non-compliant, then we will be doing a free breathing IMRT for her. So this is the way, you can try getting a balance between coverage and the OAR doses. And of course, you have to take high risk consent if, despite doing all that, if you are not able to achieve your dose constraints. But by and large, up to, our cutoff is around 3 to 3.5 gray for accepting any plan. Maximum, this is the worst case scenario. Then if it is exceeding that, then we take a high risk consent and then go ahead with radiation. Yeah, and for patient for DIBH, the RPM system, we have RPM system. But if the patient is having is to be planned for DIBH with ABC, it will be good, because there it's not the patient. We don't depend on the patient's practice or anything. It's only it's controlled with the machine, so you can refer the patient for ABC based breath hold.
Like for patients who undergo targeted therapies, how long you can wait after surgery to start chest wall irradiation?
Targeted therapy, you mean to say anti-HER2 therapy?
Anti-HER2 therapy or anti-HER2 therapy or some form of
So
yeah.
anti-HER2 therapy,
We can
there
definitely
is,
give it
yeah, there is no
uh,
need to give any gap. There is no need
yeah.
to worry. They are safe. I mean, we don't even bother to see, I mean, when their maintenance is going on. Anti-HER2 therapy, there is nothing to worry. But with CDK4 inhibitors, you have to advise the patient to start it after radiation is completed.
Uh, because some of the centers uh, are managed by medical oncologist or surgeon, and they refer the patient after completion of transmab, and are sent to radiation oncologist almost after 1 year or so.
So
After
that is what I mean. We have to sensitize this that radiation is the main local treatment, because if she not receive local treatment, she will end up having recurrences. Then what I mean, anti-HER2 therapy is not going to control the local disease as much
yeah,
as
that's
radiation can control.
that is practice most of the time, but most of the other centers where they don't have radiation set up at their place, they tend to hold on to the patient as long as possible.
But then I would say giving radiation after 1 year makes no sense. Then our cutoff is 6 months. If the patient has come
Right.
after 6 months, we observe. We keep the patient on observation. We don't offer radiation
Yeah,
to
exactly.
such
That's what
patients.
I wanted to know.
Yeah.
There's one more question, ma'am. Ma'am, is it advisable to keep bolus in every fraction of radiation in MRM patients, or we can keep on alternate days?
So, our practice of putting it daily, initially our practice was to put in half the number of fractions, not alternate. We used to put in 7 and removing the remaining 8. So this is how we used to do create 2 plans. But it was a dissertation of one of our MD students. So he had seen the topography of the chest wall recurrences that had happened. Consecutive 100 patients were evaluated, and we saw that maximum recurrences were along the scar, 3 centimeter within the around the scar. So after seeing that, we now put bolus on over the chest wall every day, and we don't find any issue with the patient treatment tolerance or interruption or anything. Our grade 3 rates are, I mean, very few. I mean, we have to I mean, remember कौन से patient को grade 3 हुआ था. So it's very less, 1, 2, 3% only.
It's rare to find the grade 3 skin reactions.
Especially because of hypofractionation. So now it's
Right.
becoming rarer and rarer.
Yeah. True. So I think we come to an end of this session, and very nice session actually. I think the students must have learned a lot from your presentation today. Thank you
Yeah,
so much.
thank you. And sorry for overshooting the time.
No, it was worth actually to hear you for this extended
Yeah,
time
and it's
also.
too late. So I'm sorry for that also. Unfortunately, I couldn't make it for 7 p.m. because of Ramzan.
Fine.
Correct.
Yeah.
So, Aditya,
Yeah,
let us
yes,
conclude.
yeah,
Yeah.
yes. So on
Yeah.
this note, I would like to conclude this session. I would thank Dr. Neha ma'am and Dr. Tabassum ma'am for having you all in this session.
Thank you.
Yeah.
Oh, thank you.
Thank you.